Irene. Thank you, Vanessa. Yes, the recording is in progress now. All right, okay, so welcome to this webinar. This is a monthly webinar series focusing on statistical and machine learning methods that have the potential to promote health equity. What we mean by that is, for example, methods that can shed light on the complex factors underlying inequalities or fairer algorithms that appropriately take into account the biases that exist in biometrical data sets. And this series is co-hosted by the Alan Turing Institute and specifically the Health Equity Interest Group there, and the UCL Statistical Science Department, as well as Data Science for Health Equity, which we call DISHI. And a bit more about DISHI. So DISHI is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. Our aim is to ensure that the latest research and innovations in data science, machine learning, and AI improve everyone's health, and especially those in underserved populations. And I'm guessing that the people here have already heard about this, but if this sounds like something that you're interested in or would like to know more about, then there are quite a few ways to get involved, and we've already posted some of them in the chat. But feel free to have a look at them. There's a very, very active Slack channel and a lot of other interesting events going on that you can join and have interesting discussions. But importantly, today we have some more news, and that is that tomorrow we have the newest edition of the DISHI Download, which is a virtual event for DISHI members to come together, share new insights, talk about work and connect. And we've recently launched quite a few new themes, which are essentially working groups on specific topics. One of the themes is our statistical methods for health equity theme. And we will present all of the new themes, including what we do in the stats theme, and we will be discussing the webinar series and our other events. So please come along for that if you want to know more and want to join, or just are interested in any type of DISHI events. But enough about DISHI now, because we have a very, very exciting talk to get to. It is my great pleasure to introduce today Dr. Irene Chen. Irene is an assistant professor in UC Berkeley and UCSF's Computational Precision Health program with a joint appointment in Berkeley EESC, and she's also a member of the Berkeley AI research. Irene received her PhD from MIT EECS and her joint ABSM in applied maths from Harvard. She's worked at Dropbox and Microsoft Research, and Irene studies machine learning for equitable healthcare, so perfect for our DISHI community. Her research focuses on two main areas: firstly, developing machine learning methods for equitable clinical care, and secondly, auditing and addressing algorithmic bias. Today, we will hear her talk about LLM's bias and the implications for equitable healthcare. Now, if your cogs are already turning during the talk, please feel free to post your questions in the chat, and we will put them to Irene during the Q&A after the talk. And if not, you can ask them after with your mic or in the chat as well. But now that's all from me. So please join me in giving Irene a lovely virtual welcome. And Irene, the floor is yours.
Thank you so much for the very kind introduction. I'm thrilled to be here. I've watched many of these seminars myself, and so happy to share more of my research and that we can further the conversation. So as mentioned, I am a professor at UC Berkeley and UCSF with many joint appointments, including as a faculty member of Berkeley AI research. So lots of affiliations to thank, which make my research possible. All right, so as the community likely already knows, as we deploy more algorithms in healthcare settings, we have started to find very egregious examples of algorithmic bias. So although algorithms themselves are often inscrutable, we are getting more insight into ways that bias may manifest. On the left-hand side is research from colleagues at Stanford who looked at dermatology algorithms. So these are algorithms.
1 second, Irene, sorry. We can't see your slides, so if you could share them again.
Oh, no.
That's just because I was sharing my screen. So.
Oh, all right. Take two. Okay. Can you see them now?
Yes, perfect. Thank you so much.
Can you still see them now?
Yes.
Okay, great. Where were we? Dermatology data sets and algorithms. So they trained an algorithm, or they examined some of these dermatology state-of-the-art algorithms, and they found that they were primarily trained on data from fair-skinned patients. So they performed poorly on darker-skinned patients, as you might expect. One of the solutions they proposed then was to create what they called a diverse curated clinical image set to include both fair-skinned and darker-skinned patients and anyone in the continuum between, which then increased performance for these dermatology algorithms in a very encouraging show. And another example, care management algorithms, which are used to predict a patient's health for the upcoming year and are used for allocating resources in insurance companies and hospitals. These algorithms were proven to have racial bias, particularly because they were trained on cost of healthcare as opposed to need for healthcare in the upcoming year. So in this case, it was improper label that was used that then had an impact on the downstream bias of the algorithm. So in both of these examples, we are taking an algorithm and then we're looking at the impact on patient subpopulations on the left-hand side because of things like imbalanced data sets, and on the right-hand side because of things like bad labels of the algorithm. In my own research, we looked at chest X-ray classifiers. So these are ginormous data sets of over, say, 300,000 chest X-rays in one data set. And we found that even though it's very large, representative, diverse data set, even though the labels are basically correct, this person has pneumonia, this one has a collapsed lung, etc., we found that the classifiers still produced they consistently and selectively underdiagnosed different patient populations. So we looked at the cross product between sex and race and found that certain subpopulations, for example, Black women, were receiving high underdiagnosis, meaning that they might be at risk for being overlooked by the algorithm. So this would be, I think, represents another curious case of data sets not solving the problem, labels not solving the problem, but something else is going on that we don't quite understand. Again, I feel like I'm preaching to the choir here, but I want to emphasize that equitable healthcare is particularly challenging for not just the systemic reasons, but also the technical and data challenges that can arise from it. As surprise to nobody here, healthcare as a system has existing health disparities. In the US, Black women die in childbirth at 3 times the rate compared to white women. These results have been replicated even when controlling for socioeconomic status, for example. The data that we choose to collect can be skewed as well. In genome-wide association data sets, 96% of these large data sets, which are prized for their size and how much they'll change population health, researchers found in 2008 that 96% of the participants are of European descent of all GWAS data sets, which, as you can imagine, does not represent the global population. The reason that these data sets and the uneven sample sizes are important is the fact that subpopulations, so different patient populations, can face differences in the data distribution. For example, men and women can have different symptoms and representations of heart attacks. For men, it's more sharp stabbing pain, and for women, it can manifest as more of a stomach ache or even back pain. Not understanding these differences might result in differences in treatment and maybe even delays in care. So with a biased existing healthcare system creating biased data, is it any wonder then that algorithmic bias might occur? My research, and maybe the point that I want to really hammer home in this talk, is that the entire machine learning pipeline is up for grabs. There are things that we want to focus on. These are problems that we want to solve, and they should target and really serve patients who might be overlooked by the existing system. We want to fund projects as well. Then we move into data collection, how we collect these scores, how do we combine data sets, how we think about issues of privacy and patient consent here. Then we think about the outcomes. What are we actually training on? What actually makes sense there? Then there's algorithm development and bias audits that are at the very end, which many of you might be more familiar with. But I want to say that the first few steps are also incredibly important. And I hope that you can think about your own work and think about how each of these steps might apply. when we, so my research looks at this entire machine learning pipeline. When we think about large language models, though, as they start to enter the scene, we have even more questions. For example, how do large language models propagate existing race-based medicine? So this is a study out of researchers, colleagues of mine, and they essentially asked different language models what they would call race-based medicine questions. So asking things about the genetic basis of race or the skin thickness between different races. And then they had clinicians rate them based on whether or not they were concerning or not concerning at all. And in fact, across the board, many different companies creating many different models found that these models seem to have very concerning responses related to how race-based medicine is practiced and propagated, including espousing ideas and medical concepts that are considered quite outdated now. When we think about the way that models might be used to make differential diagnosis, these researchers, including some colleagues at UCSF, looked at for a given patient note, if they changed whether or not the patient was what race or what gender the patient was, did the diagnosis for the exact same note otherwise change? And although it's a pretty complicated graph with a lot of subtlety going on, I would just say the smattering of color and the fact that it's not a consistent pattern shows that in fact the model is selectively and again diagnosing people at different rates purely based on their race and their gender, which is also concerning. Lastly, there's some questions about the subjective assessment of patients as well. So beyond differential diagnosis, does the model think of people as having exaggerating their level of pain, for example, the chart on the right, and as well as whether or not they're abusing pain medications, whether or not they're telling the truth about their injury, et cetera, on the left-hand side. And so again, it's a big complicated chart, but I sort of want to emphasize that any non-overlapping confidence intervals, any bars that are different sizes for different groups indicates that there's something going on here, that it's not consistently applying medicine or applying recommendations to different groups, even for the same words describing these patients. So that's concerning as far as large language models go. The promise, though, is that models have a lot of opportunities to improve existing healthcare system protocols. One example here is researchers looked at the comparison of physician and chatbot responses to questions asked on, it says here, a public social media forum, but it was essentially Reddit, and it was specifically the subreddit r/askdocs. And in fact, outside evaluators found that they preferred the chatbot responses to physician responses most of the time, 78.6% of the time, because physician responses were very short, only 52 words in median versus 211 words in median. And in fact, there was a lot more empathetic responses from the chatbot as rated by outside evaluators, which is raising questions that maybe we could start to use these models for improving different parts of the healthcare system, even if we're not quite ready to let them diagnose people full time. In today's talk, I want to talk about two recent projects that I've been working on that are both under review actually right now, specifically related to how we can rethink large language models. First, we'll talk about how we can develop some guiding principles for health equity in large language models, specifically in the topic of maternal health. And then we'll transition down. So that's more on the problem selection stage of the pipeline. And then the second one, I want to talk about how we can learn different reasons that people switch diseases. Why different patients switch treatments, and how we can think about using large language models there to better understand the current healthcare system. Diving in, one project that I'm very excited that I got to work on recently was how we can think about maternal health, how we can think about guiding principles for large language models, and how that all plays in with health equity. So the reason we focused in on maternal health is that it is actually a perfect storm of many different confluences. One is that there's a large existing body of NLP work looking at social media, looking at interviews with patients, really trying to understand what is going on in the lived experience of women and birthing people. The second thing is that it impacts the entire population, even if you yourself are not able to give birth or choose not to give birth. In fact, you were once a baby and you were once, a product of maternal health yourself. And then there are also a large body of existing health disparities and worsening racial inequities that people are flagging. In the United States, that Black-white maternal morbidity gap that I mentioned earlier is actually widening over recent years, and in fact does not seem to be getting better in any way. And that is precisely what's being demonstrated in this graph as well. So here we have the deaths per 100,000 live births. And as you can see, not only is it getting worse for each group individually, the gap between the groups is also getting worse, which is very, very concerning. So the question that my collaborators and I set upon was thinking about, well, we have large language models, which are have a lot of promise, but have a lot of potential for bias. How could we figure out what they should be used for, and what should we go around and telling people who, and what should we go around and what should be the best practices for that? We, as a variety, so our team included clinicians, included NLP researchers, included anthropologists, a lot of different skill sets. But we found the best way to go about doing that was, in fact, just to ask the people who would be most affected. So we tackled this in 3 different ways. One, in partnership with the American Association of Medical Colleges. So this is a nonprofit that works across different medical colleges to develop curriculum and otherwise provide guidance. We hosted a 400-person workshop specifically focused around maternal health equity and specifically related to large language models. Then we thought, these workshop attendees are a self-selecting group, right? They're just choosing to spend their random day in May on, talking to all these people, offering their opinions. What if we also wanted to ask the random healthcare professional and also the average woman or birthing person who might have opinions that they also want to share? So in that way, we use the Prolific platform, which is a great asset to be able to reach a variety of people, particularly a pretty diverse population of users on the platform, to get feedback from them as well. And one of the things that I'm quite proud of what we did, and I think we found the most useful, is that we actually gave them access to a large language model themselves. So the first thing we did was, but even before this screen, we we gave them a little primer on what large language models can and can't do. Not necessarily like capacities, because I think that is being sort of adjudicated now, even with ongoing research, but much more so about what a chat model is and what kinds of questions we should ask it. For example, here we give examples on the left-hand side. And then we gave people free access to use the large language model for roughly about somewhere between 30 minutes to an hour. Everyone in the study got access to our GPT 3.5 access token, and they could submit questions and get responses from the model somewhat instantly. As you can imagine, these things were delayed as well. And also, I think we got rate limited. And we recorded then all of the data, all the questions people asked, and all of the responses to better understand what people really were interested in learning about from the model, or what kinds of use cases they thought they would want to use the large language models for as it relates to maternal health equity, or just maternal health. After they interacted with the large language model, we then asked them if it seemed like it was accurate, if they had any notes. And at the very end, we asked them to rate what kind of values that people should keep in mind while using these large language models. So this is a pretty quantitative crowd. So I'm going to open with our quantitative results, and then we'll probably move into the more qualitative results, which I think could be quite an interesting insight into these people's perspectives as well. So on the quantitative side, we asked them to rank these, I believe it's 11 qualities that they thought would be important. And specifically, we stratified by the 3 different groups that we interacted with. So we have workshop participants, we have healthcare workers, and we have birthing people. I find that these graphs can be hard to interpret in aggregate because it's a lot going on. So let's just focus in on a few things. The first thing we noticed immediately was, compared to the other 2 groups, birthing people, which is this dark blue, that group, women and birthing people, really prioritized privacy and autonomy. And intuitively, this seems to make sense because they don't want their data shared with a lot of people, and they'd also like to retain some measure of how they are in control of their situation, especially as they go through this potentially scary, potentially dangerous experience. Alternatively, healthcare workers who work in maternal health prioritize transparency and accountability. So if you can imagine, this is the medium shade of blue, the middle value on the bar chart. You could imagine that healthcare workers are really concerned about who will be blamed if things go badly. Will they be blamed? Should they be checking everything that the large language model says? And how do you go about doing that? As well as transparency. What data sets are these being trained on? What kinds of people have been included in the analysis and not included? And also, how does a large language model work? Especially if they're going to be held accountable potentially for using these results, they would like to understand the mechanism of what's going on. And then lastly, our workshop participants, again, these were people who self-selected into this American Association of Medical Colleges Health Equity Workshop for Large Language Models. So people who are really passionate about these specific topics. This is our lightest blue bar. And these people really valued inclusiveness. And we found that to be quite striking as well, that they seemed to really be interested in making sure that the most people were represented and taken into account in the process. Which is, certainly they're all important values, but it's interesting to see which groups seem to prioritize which ones in comparison to the other groups. As a qualitative summary of all the feedback that we got, I'd like to highlight 3 points. One is that patients had generally positive hopes. I think when you work in bias and health equity all too much, you might start to get pretty negative. And it was quite heartwarming to see so many people quite excited about large language models and the potential there. Quotes included, I wish AI had been around when my son was a newborn, something to do during late night feedings, something to make me feel like I wasn't alone. Participants responded saying that when they wanted a quick answer, it'd be nice to not have to go to the hospital and wait in line and book an appointment, but they could just get something quick. And also could be empowering for people who are lacking social and financial supports, such as young mothers. On the flip side of the coin, there were some concerns raised. I should really, to hammer home this point, actually, I would say like 80% of the responses were really positive, really optimistic about what large language models could have, which maybe reflects a lot of the messaging about large language models in the general public, actually. But all the same, people raised concerns. One thread of concerns was about the place in the healthcare system. For example, if AI were to replace nurses and doulas, the concern would be that mothers would get fewer care, that nurses and doulas might see people seeking less care. They'll see fewer people seeking care, meaning that they didn't want nurses and doulas to be priced out or replaced otherwise with AI. There was a lot of concern that the healthcare system might start cutting corners if they think that AI can replace nurses and doulas, that they might want more profit, that they might have a different incentive structure than just purely helping people going through the maternal health process. There was also some guidance about large language model developers. So the thought here was that there should be transparency in the sourcing of the data, as well as a more targeted approach to the solutions. Instead of just having a cool, shiny tool, it should be targeted and designed around specific questions in maternal health that people can't solve. And instead of paying lip service to potential bias problems or obstacles, it would be nice if the AI could actually solve things, which I found to be quite striking as well. And then in our partnership with the American Association of Medical Colleges, we came up with 9 foundational principles, I guess you could say. And then they made this really nice infographic about them, which I wanted to share here. The font is a little hard to read, but sort of at a high level, there were 3 types of principles. One of them was that you should figure out the context of the situation. So we should include the voices of birthing people. We should hold on to the human empathy, emotion, relationships of complexity, and then be aware of power dynamics. So that's that first row of hexagons. The next one is that we want to figure out the way that the technical process is modeled. So could we make sure that the agency autonomy of the birthing people are centered? What about the politics and implications of the measurements, as well as the outcomes that we're optimizing over? All of that should be taken into account, specifically in the maternal health setting, to be quite important and impactful. And then lastly is centering people that are at the heart of the impact as well. So respecting and supporting your data sources, fighting against inequity, and protecting all groups of birthing people. And then lastly, learning from maternal health traditions and communities. So overall, I would say that what things that I learned through the process is that giving people access to the large language models were key. Helping people seeing how they used it and then asking them about it was the core fundamental part of our entire study. The other thing that I think is probably not exactly surprising to this audience, but different populations have different priorities. For example, healthcare workers wanting to know about accountability, compared to all the other groups. And then lastly, I want to emphasize that this is an ongoing conversation. The technology will continue to improve. People will continue to evolve their understanding of these tools and their opinions on it. And so I hope that we can use this as a framework to continue to understand how we should go about using these tools and implementing them into the healthcare process. As the second project that I want to cover today, this is moving a little bit downstream in the machine learning pipeline. So instead of the problem selection, which do we solve in the first place? Who should we include in this decision making? I want to move a little bit closer to the outcome definition perspective, which is how can we figure out the right things we should be predicting for? We think a lot about treatments in the medical space, and can we think about patient-centered reasons for treatment switching? This is with a large team of folks from UCSF and also Brigham and Women's Hospital in San Francisco and Boston, respectively. So when we provide treatment to patients, we are often interested in many things, but mostly how it relates to their trajectory. So here we have patients A, B, and C, and then we have some notion of their biomarker, their disease severity, where lighter color means mild and then darker red means severe. So patients A and B are starting pretty mild and they get pretty severe, but then patient C somehow is very severe and gets pretty mild. So maybe something's going on there. And what we learned from my research and previous projects is that a lot of the confounding factor of this often is the treatments that they're on. So here we have all three patients are started on this blue treatment. We call this a first-line treatment. But then patients B and C are switched to green and yellow treatments respectively, potentially because the blue one wasn't working, because of other reasons, we're not quite sure. And in fact, there's a wide variety of reasons that patients switch treatments. It could be disease progression. The disease gets worse. They want to treat it more aggressively now. There could be weird side effects with their medication. There could be patient or physician preference. Some physicians just always like starting with one medication. Some patients might not like taking a pill every single day. They'd rather take a pill once a week. And then there might also be socioeconomic factors, for example, cost of medication that they want to take into account as well. This information is often only locked up in clinical notes. So as explained earlier, large language models then provide this opportunity to figure out how we could unlock this information. As I mentioned, there's a lot of promise, there's a lot of potential papers that might be relevant, showing that you can extract medical information pretty reasonably well, although there are, of course, some serious caveats, as I mentioned earlier in the first half of this conversation. So our goal here would be to identify medication switching reasons from tabular data. Those are figure out which patients are actually switching, but then use the notes to be able to figure out why they're switching, being able to quantify and identify those factors. At a high level, the experiment overview kind of looks like this, where you would look at patients and figure out which medication they were on or going to be on, and then get all the notes around that time to figure out what the underlying reasons are. Some part of the data set is then used for validation, hyperparameter tuning, specifically on prompt tuning, prompt engineering, as some people might be familiar with. And then there will also be an evaluation both from clinicians as well as in an automated form. Treatments, there's a lot, talking to our clinical collaborators, there's a lot of treatments that people are interested in figuring out why patients switch from group to group. On the right-hand side, we have treatments that are available for rheumatoid arthritis, and not to mention different oncology drugs, statins, et cetera. Today, we're going to focus, though, on contraceptives, and that's what we use as our first pilot case. So in the US, different countries are different, but in the US at least, that's about 50 million women are on contraceptives. That's about 65% of all women between the ages of 15 to 49. A huge percentage of them discontinue use, 44% discontinue use within the first year, but a lot of those people resume use within the next 6 months. About 76% of the 44% will then resume use, potentially of a different class of contraceptive. And there's a wide standing amount of NLP research that already exists that uses things like interviews and social media data to better understand contraceptive switching. So using the UCSF data set, so this is every patient who's come into UCSF in the last 20 years, I believe, we created a very strict cohort switching, contraceptive switching cohort. So we wanted to think about people who are using long-term contraceptives, so not condoms, not emergency contraceptives. We wanted data that had a listed start date. We wanted to remove duplicate medication orders. We wanted to remove patients and encounters where there weren't clinical notes associated with the encounter, so there wasn't a sort of a reason what's going on. And then we also wanted to remove patients who didn't switch medication. So we end up with a cohort of about 2,000 patients total, with about 2,800 medication switching. When we look at the demographics of this cohort, this table is quite complicated. There's a lot of busy stuff going on. But if we highlight a few rows specifically, we have the different race breakdown of the overall cohort, as well as a cohort that switched contraceptives and a cohort that never switched contraceptives, that the first one really stuck. And we see that white and Asian patients have much higher rates comparatively of no switching compared to Latino and Black patients as well. And these are statistically significant results based on the sample sizes, as you can see. And this started to plant the seeds that, again, not everything in my research is an equity problem, but oftentimes many things secretly become equity problems the more you look. So our next step was then to extract, as I mentioned, these switching reasons from these notes and see what's going on. One of the ways we wanted to make sure that our model wasn't going to go completely bonkers was we got some clinical review. So this was using 5% of the patients. We gave them to our amazing clinical collaborators who sat down, poured themselves a giant pot of coffee, and just went through and looked at whether or not the LLM extracted the correct switching reason, and also whether or not the switching explanation had any hallucination. So hallucination here is defined as information that was not included in the note at all. They just sort of pulled it from the air. And overall, 91% of the reasons that were audited seemed to be correct. This is very promising. And in fact, 98% of the reasons had no hallucinations. About 2% had hallucinations, which I would say is not like amazing. I certainly wouldn't want a doctor that like was going to go completely bonkers 2% of the time, but it was promising enough that we can start to maybe learn a little bit more about these patients and their switching reasons in a population level for now. Another way that we evaluated the large language model was we compared it to other NLP methods. So GPT-4 sits on a stack of other NLP methods that people have used, particularly for electronic health record data. So against all of these models, we start to see that the amount of training data goes up, the performance of many of these models also goes up. Because we're using GPT-4 in a zero-shot fashion, the performance there does not change at all. And in fact, the performance in the zero-shot fashion outperforms many, many other models, even as they increase from more and more training data. So it seems like using a zero-shot model that's more of a general model, in this particular case, seemed to outperform many of the other models we evaluated. Lastly, we took these extracted reasons and we applied a HBDC scan, which is a topic modeling method that's a bit more sophisticated than, say, latent Dirichlet allocation, and specifically takes into account the contextual embeddings that are used in large language models. So here we have it, and they also dynamically decide what number of topics that were the most representative. Here we have 9 topics. There's a bunch of different ones that pop out. Topic 1 seems to be about symptoms, for example, breakthrough bleeding or weight gain. Then we have things about patient preferences, like not wanting to take a pill every day, things like the IUD being malpositioned, having a weird rash, for example. But overall, sort of one of the things I wanted to focus on then was that we were most interested in these socioeconomic factors, and that becomes topic 8 here. So this is the insurance coverage topic, where patients were worried or figuring out if the insurance would cover which medication, which class, and then therefore switched medications as a result. When we look at the topic enrichment values across these 9 topics, when we isolate down the insurance coverage topic, for example, we see that that topic covers a disproportionate amount of the Latinx, Black, and multi-race patients instead of compared to, say, the Asian, white, or other patients instead. And I think this sort of highlights demonstrates the ability of large language models to extract out these nuanced reasons and allows us to understand at I would say, an aggregate level what's going on to, in fact, highlight health disparities in medication switching reasons. In this case, contraceptive specifically. So I want to be clear that it's not like we expect people to come in and we can say, oh, this person is definitely not going to be able to afford this medication, therefore we shouldn't give it to them. But instead, it's much more about highlighting places where health disparities might exist that we might not might not have fully understood, that we can start to unlock because of large language models. So in summary, 1, we can leverage large language models for unstructured clinical notes in zero-shot settings. 2nd, we can, in the case of contraceptives, we can break it down into different topics or different reasons. For example, having weird side effects, adverse events, as it's called here, or patient preference about not wanting to take a pill every day, using oral contraceptives, and also whether or not your insurance will cover it and pay for it. These findings, we believe, will have enormous downstream impact, for example, in how we extract treatment protocols in electronic health records, but also not only in the extraction, but also in any kind of prediction and treatment effect algorithms that can be used. As you can imagine, what if we only isolated our algorithms to learn treatment effects based on clinically relevant reasons and didn't take into account things like insurance coverage? How would medication be different? How would our treatment switching protocols be? And I think the large language models, as they currently exist today, in models that we have access to right now, are already starting to provide a little bit more light and understanding into the complex, heterogeneous patient population. All right, so today I showed you 2 examples of cases where large language models can be maybe helpful, maybe hurtful as relates to health equity. And I even opened with a whole discussion about bias in not just large language models, but health algorithms in general. So there's a question here of, if we use more algorithms in medicine, so if algorithms were used more in medicine, then the wording here is a little convoluted, but essentially biased and unfair treatment based on patients' race and ethnicity would, meaning basically racial bias in medicine, would get better, stay about the same, get worse. And so I'm not going to put you guys on the spot. I found that other audiences do not, maybe don't always love voting openly for everyone else. But I want you to think about in your head, if you think the current bias in medicine situation would get better because of algorithms, stay about the same because of algorithms, or get worse because of algorithms. And in fact, the Pew Research Center in the US did a study looking at precisely this. And so they found that 51% of Americans thought that that racial bias in medicine would get better because of algorithms. In fact, there's a quote here that AI isn't going to have preconceived ideas about patients' symptoms. It will just analyze the data. I hope maybe from today, maybe from before, that this audience knows that this is not true, that the data will in fact have preconceived ideas because of the way it's collected. 33% said AI is programmed by humans and humans are biased, therefore will stay about the same. And then 15% say that AI is trained on existing data sets which are already biased by the humans who made them. So they think that the bias in medicine will in fact get worse. as someone who thinks about this topic all day long, 7 days a week, I would say that I don't know where I fall. I think it's an interesting question to think about, and it certainly will change, certainly even over the next few years, particularly because of large language models. I certainly don't believe in the reason that the blue people say here, but I am optimistic that there are ways that we could leverage some of this new technology to improve equity in healthcare. And I'm optimistic that folks in this call, people that are listening, can start to help make progress in that direction. And I'm very encouraged by many of the results I've seen in this seminar and other works as well. So to leave, I don't have an answer for the actual question, but it's sort of leaving you with a little pondering. In conclusion, if you have not been paying attention at all today and you're sort of just tuning in, I would say there are three main takeaways. One is that the machine learning pipeline is complex and has many stages and is susceptible to bias in all of them. So are you tackling the right stage in your algorithm? Do you need to move upstream? How can bias be affecting your machine learning pipeline? Second, although equity problems are also societal problems and systemic issues and people problems and all kinds of things, there are also computational challenges. So things like label noise, missing data, misalignment, all of these can come into play and affect your model. And I would challenge this group to think about all the computational ways that equity problems can manifest. And then lastly, the end user has to be kept in mind all the time. When you're running like a social media app, your end user is just an app user. But when you're in medicine, your end user is a patient, is someone who is coming in their hour of need, in their darkest hour. Can you help them? And through that framing, the questions then become, how will this model even get deployed? What users will be affected? Will all users be affected positively? And then lastly, what could possibly go wrong, which is something that we really need to think about and think about continuously. So if you have any questions, I love to hear from this audience, but also feel free to reach out to me otherwise if you other questions come up for you. Thank you so much for listening to my talk.
Thank you so much, Irene. This was brilliant. I absolutely love this, and I really agree with your point on considering the context so much and looking at all of the points in across the pipeline. I think it's really, really important. And now, as we get to the Q&A section of today, for all audience members, please feel free to either raise your virtual hand, or post your question in the chat. There's already 2 questions from while you were talking, Irene. So maybe right now, Christopher, if you would like to ask your question, please go ahead. If you're still here. Maybe let's go to Chelsea. Chelsea also had a question, if you would like to ask your question now.
Sure. Thank you so much for your presentation, Dr. Chen. Regarding the Pew research, I was curious to know if the researchers completed, yes, that one, on the use of artificial intelligence addressing healthcare bias. Have you seen any research on polling that has looked at how the respondents have responded based on their own race, just given that there may be some differences based on the race of the respondent and how they think about AI in health?
Yeah, that's a great question. I have the link at the bottom if you want to dive into more of the poll results. I don't remember seeing it broken down by race. And in fact, this slide that I'm showing here wasn't even the top line finding from that specific set of surveys. In fact, the top line was, as you can see at the very bottom in tiny font, 60% of Americans would be uncomfortable with the provider relying on AI in their own healthcare. So I think the overall study was focused on AI and healthcare in general, and whether or not people were comfortable with it, skeptical, et cetera. And so this was sort of a thing that they threw in at the very end about bias in general. But most of it was just about, do you want your doctor using AI at all? And it turns out 60% even though 51% think that it'll improve racial bias, somehow 60% just don't want their provider using AI in their own healthcare. So it's a bit of a nuanced, the thing I like about surveys is that you can read all kinds of conclusions into it, and it starts to help you get a nuanced perspective of the general population.
Hey, Irene, thank you so much for your talk. Really, really interesting stuff. I guess I was kind of wondering about breaking down the priorities in AI by race and ethnicity as well. I know you had that by the participant role, but that sort of seemed to be covered there. So I was also wondering if you had looked at like disaggregations of or intersections between like race and ethnicity. You had the sort of standard OMB categories, and there's some work in disaggregating that people don't exist so much as within these. There's a lot of variation within them, and so I know that's probably part on your next steps. Maybe I don't know, but
yeah, I think that it's definitely on our list of things to dive into. I would say when we have all these workshop participants and healthcare workers and women and birthing people results. When we stratified by race, we found it to be not as big of a difference as the specific groups that we were collecting from, right? So the workshop participants versus the healthcare workers versus the women and birthing people. And so from that context, that's why I chose to present the studies about the values. But you can imagine if you had one large population stratifying by race and thinking about how the priorities might change there, it would also be a really interesting question as well.
Brilliant. Ashish, do you want to ask a question?
Thanks for a great talk, Irene. I was just wondering, in terms of combating bias, right? It very much depends on how, what kind of data set was the model trained on, right? And so I was just curious, what's the way out in terms of like, do we use more open source models and model cards, and how do we systematically go about evaluating and assessing a model before deploying it? So I know the field is also not is evolving really quickly, and there are initiatives like CHAI in the US, Coalition for Health AI. So I was just curious to hear your thoughts on deployment and evaluation and assessment of models.
It's a good question. I would say right now, one of our big obstacles is that there's no regulation, there's no standard for reporting what's in these large language models. We have no idea what the data set that they use is. We have no idea what kind of training procedures, RLHF is a huge factor, reinforcement learning with human feedback. Who are these humans? How are they providing feedback? What are the principles that we're guiding there? And so oftentimes as an academic, it can feel like you're sort of screaming into the void saying, please give us more information, please help us understand. And that I would say is one of our biggest challenges. There is starting to be a growing effort, certainly in the US, about how we regulate these AI policies and policies for AI regulation, and how much they have to disclose, or how much we how much researchers are empowered to better understand these models. But as it stands now, as you see, all the two studies I presented were based on essentially black box access to these models that we then had to pay OpenAI for access for. And so I think it is a really troubling question moving forward about how we can understand basically nothing about these models except for at the very end, and what kind of research we could do, especially as it relates to health equity.
Thank you.
I think Christopher might have another question.
Yeah, hi. So I was wondering about like the identification of the racial groups themselves, not like stratifying. That was my first question.
Oh.
Wondering about like identifying, groups that are Black, Hispanic, or like suppose it says Asian, but you're Asian born in Los Angeles, or you're Asian born in mainland China. There's a big difference there. So combine it with like country of origin, language spoken, and sort of, a more nuanced understanding of race. I'm curious what any work you know of or participating in identifying more valid definitions of race and ethnicity from these type of data, generally,
Absolutely.
not necessarily in these projects.
Yeah, absolutely. this seems to relate to a question people have been asking about, like, what is race even? Is it a statistical, it's not, is it just a concept we made up as a society? Genetically, what's the basis? Sort of like, how are we figuring out what race is? I would say that oftentimes it goes back to what we're trying to study. When we stratify by race, it's not that we're so interested in the parameters of an Asian person and what that means for this algorithm, but we're rather studying racism and how that impacts how a person's lived experience through the system. So if we're more interested in how this algorithm is treating people who don't speak English well and therefore are not well understood by their clinical provider, then we can stratify by which language is listed as their primary language. And I think that could provide insight into how well the algorithm does. So I'd throw it back and say that a lot of it depends on the overall research question that we're solving, and using things like patient self-identified race is important for some settings, and as you point out, perhaps not as important in other settings compared to lived experiences about English familiarity, for example. And so we as a field, I think, are starting to set up best practices about when stratifying by this group versus when stratifying by other groups, but it's an ongoing thing.
All right, thank you. Actually, following up on that, I have a question that kind of connects to it. Because I've been thinking and heard other people talking about kind of the difference of when is it useful to disaggregate between subpopulations, and when does that actually just feed into more harmful discrimination? Do you have any input on that?
Sorry, can you restate your question? So you're asking about when it will feed into more harmful discrimination?
Yeah, essentially, when is our disaggregation of people? When is it useful to group people into subpopulations and look into the effects of our algorithms, or making our algorithms more specific for specific subpopulations? And when does that actually feed into more harmful discrimination?
Yeah, I think this also goes into the question of why do we do all these audits, and if you don't identify as being a certain group, or if you don't want to be treated differently because you're from a certain group, how do we build a system that maybe it shouldn't matter which group you say you are. The model shouldn't be treating you differently based on each group. Maybe people should definitely not feel incentivized to hide their racial identity, and thinking about how that might play into it. Is that sort of the question you're asking, Andrea?
Yes, exactly. Yeah. Thank you very much. Are there any more questions in the room? There is a paper.
No, I was just going to quickly note that the AMA guidance clearly states that all medical and science journals must report race as social constructs, so the genetic part is kind of like solved. So I think that and I fully agree with what are we measuring? Are we measuring race? Are we measuring racism in the system? Those are important things, because and the research question about it. But just wanted to point out that social construct is sort of the way it's been decided to report on now. Biological connection with race is pretty poor, and I don't see.
Yes, certainly.
Very poor. But yeah. Okay. Thank you.
All right. I'll sneak in one more question. Yes, exactly. There's a lot of resources.
A lot of resources, yeah.
We do have a Dishy library where we do save all of these resources. And if any of you have more resources to share, you can do that either right now, just pop them in the chat, or go to our website and connect with us and find the Dishy library on the website. We're very keen on growing our library, but also if you just want to have a look and see what kind of articles are out there, there's also other webinars and things to dive into if you're interested in that. And as I said, I'll sneak in another question from my side. I would be really interested in, you talked a lot about integrating the most effective people during the kind of problem selection part of the model development. Do you have any maybe tips on how to keep people in the loop for the later stages of the pipeline, for example, during the model development or the later stages?
Yeah, a lot of these become, I guess, like organizational questions. At UCSF, we're piloting the idea that you can report your algorithm. You can sort of like say, hey, this algorithm output is really suspicious. Or like, I would like some recourse. I'd like to be able to say, no, thank you, and be able to have that logged so that later on a developer can look at all the suspicious places and improve the model. So right now that exists from a clinician perspective, in a developer perspective, but you could imagine that a patient would really appreciate what's going on there, that oftentimes patients feel the most disempowered. And so if there was a way for them to come in and say, I would like to see my algorithm output, I would like to, flag this as being something suspicious, I would like to talk to a person about what's going on, all of those could be quite powerful.
That sounds great. Yes, really empowering the patient
Right.
through transparency. That's great. All right, we're perfectly on time. Thank you so much, Irene, for this wonderful presentation. And thank you all for joining. And this was fantastic. Please keep in touch on Slack if you want to. And once again, thanks, Irene. And I think we'd all want to wish you a lovely day.
All right. Thank you so much, everyone. Lovely questions. Thanks for your time.
Goodbye, everyone. Bye.